Thank you, Samuel, for that kind introduction. And I would like to thank the Kenyan Renal Association for inviting me to give this talk. We're going to change gear a bit from extracorporeal circuit and life support, and we're going to move on to some acid-based disorders in the ICU. And I've been asked to talk about metabolic alkalosis in the ICU. So there are metabolic alkalosis in the ICU, or in general, there are two groups of mechanisms for how this comes about. And the most common is usually due to a chloride salt deficit. For example, sodium chloride loss would result in what we refer to as a contraction alkalosis. And then, of course, hydrochloric acid or potassium chloride results in the addition of new bicarbonate to the body. And this is by far the most common mechanisms for metabolic alkalosis in both patients outside of the ICU and within the ICU. The second group for metabolic alkalosis is sodium bicarbonate retention. And this occurs in the context of patients with mineralocorticoid excess activities or mineralocorticoid-like syndromes. And an example here would be Conn syndrome or primary hyperaldosteronism. Now, the investigation of choice in a patient that presents with metabolic alkalosis is really the urine chloride, and along with some clinical information on the patient's blood pressure and the effective arterial blood volume, this will guide the diagnostic approach to the underlying etiology for the metabolic alkalosis. And the goal of therapy is to replace the chloride salt deficit. So if it's sodium, if it's a contraction alkalosis, you give patients normal saline. If it's hydrochloric acid, where the patient has lost potassium chloride in the urine, you replace the potassium chloride. But I'll touch on that again later. So what are the risks related to metabolic alkalosis? The first and most important are cardiac arrhythmias. And there are two reasons for this. When patients have a metabolic alkalosis, the ionized calcium fraction is reduced, and the hypocalcemia can predispose to cardiac arrhythmias. The second is hypokalemia, which is often associated with metabolic alkalosis, and the combination of hypocalcemia and hypokalemia risks cardiac arrhythmias. The second organ system that is at risk when patients have metabolic alkalosis is the respiratory system. And in particular, due to the hypokalemia, these patients often have respiratory muscle weakness, and this is often the reason for admission to critical care. They also hypoventilate, and this, along with muscle weakness in the context of hypokalemia, is often a reason we get called to the ICU for difficulties in getting the patient off the mechanical ventilator. And then with the metabolic alkalosis, the oxygen hemoglobin dissociation curve is shifted to the left, which increases the oxygen affinity, hemoglobin's oxygen affinity, and this results in tissue hypoxia. We have recently conducted a study looking at acid-based disorders at admission into the ICU, and we wanted to know what is the association of the admission blood gas with outcomes in patients who are admitted to the ICU. So we looked at 1 year's blood gases in patients that were admitted, and we in patients older than 18 years of age. And as you can see here, just around about 9% of patients had a metabolic alkalosis on admission to the ICU. When we looked at the mixed disorders, roughly a quarter of the patients had a metabolic alkalosis in association with another acid-based disorder, as you can see pointed out here. The in-ICU mortality, we could not find any association with mortality based on the acid-based disorders, as you can see there. But interestingly, patients who were admitted to the ICU with a metabolic alkalosis tended to have the lowest mortality rate. And when we looked at in-hospital mortality, again, no difference. However, metabolic alkalosis, again, although it was a 20% mortality rate, it was the lowest for in-hospital mortality. The most common causes we identified with the metabolic alkalosis was sepsis and pneumonias in particular. What happens to patients once they are admitted to the ICU? So here, this was a study looking at the base excess of 118,000 patients admitted to the ICU. And as you can see here, the longer the patients remained in the ICU, the base excess actually increased. So a base excess in excess of 2 millimoles per liter indicates an alkalosis. So you can see here that while metabolic alkalosis is probably the most common acid-base disorder in ICU patients, and there are various mechanisms for how this develops in the ICU. So what are the causes of metabolic alkalosis? We like to, at our institution, we like to divide the causes according to whether there is a contracted effective arterial blood volume, looking at blood pressure and other clinical parameters, and looking at the urine chloride, whether it is low or whether it is high in the urine. The other is metabolic alkalosis associated with an expanded effective arterial blood volume with or without hypertension. And this is usually in the context of mineralocorticoid excess syndromes, steroid use, or in patients who have renal failure or low GFR and receives a bicarbonate load, either with blood transfusions or sodium bicarbonate, with an inability to excrete this bicarbonate load. So what are the major causes with a contracted effective arterial blood volume seen in the ICU? So when looking at the causes with a low urine chloride, vomiting is by far the most common, along with nasogastric tube drainage, typically seen in patients who are in surgical ICUs. The other one is remote diuretic use. And a common one are patients with chronic lung disease who have type 2 respiratory failure and develop so-called post-hypercapnic metabolic alkalosis. A common reason for why colleagues in the ICU often struggle to get these patients off the ventilator. What are the causes associated with a high urine chloride? So recent diuretic use will be probably the most significant one to remember there. And then diuretic-like syndromes, and this is things like Bartter syndrome and Gittelman's, which are quite uncommon. And then ligands which bind the calcium-sensing receptor in the thick ascending limb of the loop of Henle, and by far the most common that we find are the use of aminoglycosides, which are cationic drugs and have the ability to bind the calcium-sensing receptor in the loop of Henle and mimics so-called Lasix or furosemide. Just out of interest, hypercalcemia is another cause of this, and patients with light chain diseases, myeloma, cationic proteins also have the ability to have this effect. So I just wanted to show you a case that I recently saw in our high care. It was a patient who presented with DKA, and as you can see, the admission blood gas here, it was a venous blood gas at presentation, not severe the acidosis. The bicarb was 21,3 and the sugar was 27,8, and there was ketones on the dipsticks. But we were contacted because the treating doctors weren't convinced based on this blood gas that the patient has a diabetic ketoacidosis. However, they managed the patients with IV fluids, and a blood gas was repeated 6 hours later. And as you can see here, after 6 hours of fluid, the pH dropped to 7,26. And as I can point out here, the bicarb dropped to just under 10. And as you can see, the hematocrit and hemoglobin concentrations dropped dramatically. So we were asked why the worsening acidosis despite appropriate treatment. So I've made this animation to explain the pathophysiology behind this. So in patients with diabetic ketoacidosis, the hydrogen or the proton of the keto acid is buffered by bicarbonate, which results in a CO2 and water formation. The sodium, the anion of the keto acid is excreted along with sodium in the urine. And because there is sodium loss and the sodium content is reduced, the ECF volume becomes contracted. Hence, the blue box becomes smaller. Also, because these patients have hyperglycemia, they have an osmotic diuresis, which also results in sodium loss in the urine, further contracting the ECF volume. And hence, this patient has what we call a contraction alkalosis. But as you can see there, nothing has happened to the bicarbonate content except for the hydrogen that was buffered by the bicarbonate in the patient with the keto acid. When we start administering IV fluids, normal saline, Ringer's lactate, etc., we re-expand the ECF compartment. And as a result, you unmask the so-called metabolic acidosis. So this is a classic example of a contraction alkalosis in a patient with DKA, and DKA can often be missed because of this so-called contraction alkalosis. So I just want to focus a little bit more on the common cause of metabolic alkalosis seen in patients in the ICU and outside of the ICU, and that is metabolic alkalosis due to vomiting or nasogastric tube drainage. Now, for this to develop, you need two conditions. The one is you need to add bicarbonate to the body, and the second is the metabolic alkalosis needs to be maintained. So this is the normal fate of hydrochloric acid secretion that happens to us all on a daily basis. So in the parietal cell here, we have water and carbon dioxide, and under the influence of carbonic anhydrase is converted into a carboxylic acid and eventually into hydrogen and bicarbonate. The bicarbonate is exchanged for chloride from the ECF compartment. And as you can see here, a bicarbonate has now been added to the ECF compartment. The chloride, along with the hydrogen ion, gets pumped out, and the proton pump exchanges potassium for hydrogen, and we have hydrochloric acid now in the stomach. Now what happens is the bicarbonate in pancreatic juice that we gained during the chloride bicarbonate exchange in the basolateral membrane, along with the hydrochloric acid, buffers the hydrogen again, and we're back to where we start off with CO2 and water. And here, as you can see here, CO2 and water. So just before we have a meal, we actually have a condition in our body called an alkaline tide. And studies have found that just before we eat meals, that patients or patients' bicarbonate ion concentrations can go up to 30 moles per liter before they actually have a meal. But this returns to normal after they have a meal, and the bicarbonate in the pancreatic juice gets secreted and buffers the hydrogen as part of in the hydrochloric acid. Now, what happens when we vomit? So this is how essentially what happens is the hydrochloric acid then exits the stomach from the top. There is no need for secretion of pancreatic juice, and the bicarbonate remains in the blood, hence causing the so-called metabolic alkalosis. Now, in order to maintain the metabolic alkalosis, this is really the function of the kidneys. So this is the proximal convoluted tubule here, and you can see the nephron lumen over there. Because these patients are ECF volume contracted, sodium along with bicarbonate is absorbed in an attempt to return the ECF compartment to normal. What happens is when the vomiting has stopped, the metabolic alkalosis remains, but the patient now consumes food again, and sulfur-containing amino acids then get filtered along with sodium, but the sodium gets absorbed and the sulfate has to now be excreted with a cation. which is unfortunately not sodium because there isn't enough sodium to accompany the sulfate during excretion. So what happens is potassium gets exchanged for hydrogen ions, and the potassium gets excreted with sulfate in the urine in the form of potassium sulfate. But what has happened now is the proximal convoluted tubular cell has gained a hydrogen ion, and this has resulted in an acidosis within the cell. So in fact, what happens is when patients are vomiting, despite them having a metabolic alkalosis in the ECF compartment, intercellularly, they actually have a metabolic acidosis. Now, this acidosis inside cells stimulates sodium bicarbonate absorption. And because these patients are ECF volume contracted and their RAS systems are activated, they have high concentrations of angiotensin 2. And this angiotensin 2 also stimulates sodium bicarbonate absorption. And this low pH inside cells, along with angiotensin 2 in the blood, is what maintains the metabolic alkalosis, even after the vomiting or the nasogastric tube drainage has stopped. So the first step in the diagnostic workup, as I've pointed to earlier, is really to look at the chloride ion concentration in the urine, along with the blood pressure and the ECF volume of the patient. So you can see here in patients that are ECF volume contracted and have vomiting or recent diuretic use or remote diuretic use, the chloride ion concentration is going to be very low. In fact, it will be under 10 millimoles per liter. However, patients who have recently used diuretics, the chloride ion concentration will be higher. Now, just on this diagnostic step here, what one has to do, if your labs have the ability to do a diuretic assay for hydrochlorothiazide, thiazide diuretics, or loop diuretics, a sample of urine can be sent to the lab, but it has to be a sample where the sodium and the chloride concentrations are high, because the likelihood of the diuretic still having an effect at that time and having it in the urine will be higher. You shouldn't be sending it on this sample, because the chances of identifying the diuretic is smaller. So you need to send it on a sample where the sodium and the chloride concentration is high. If you don't have the ability to send away to do diuretic assays at your facility, what you can then do is to do sequential urine chlorides on on a daily basis. And what will happen as the effect of the diuretic wears off, the chloride concentration in the urine will eventually move to this where there is remote diuretic use. So in other words, the chloride concentration will initially be high and will eventually taper to less than 10 millimoles as the effect of the diuretic wears off. The treatment of the common causes of chloride salt deficit. So it's quite obvious here. You need to address the underlying cause. So if the patient is vomiting, you need to address the vomiting. You need to look for gastritis or whatever is the etiology for the vomiting. If there's nasogastric tube drainage, this of course needs to be removed. However, some people have mentioned that if you inhibit the proton pump and you're therefore not making hydrochloric acid, this can also be used to address part of the metabolic alkalosis. For contraction alkalosis, it's really the replacement that these patients don't really have, they haven't gained bicarbonate. They have a contracted ECF, which has simply increased the concentration of the bicarbonate, but the bicarbonate content hasn't changed. And simply replacing it with sodium chloride or normal saline will return the metabolic acidosis to normal. Vomiting and nasogastric tube drainage, other than removing the etiology and addressing the cause, adding KCl to normal saline is of paramount importance here. So as I've mentioned to you earlier, with inside cells have actually lost potassium, and hydrogen has entered the cell, and the cells have an acidosis intracellularly. Now, what surgeons typically do is they refer to this as a chloride responsive metabolic alkalosis, which we don't like because it doesn't address the actual pathophysiology of the type of chloride salt. Because chloride is not excreted on its own in the urine, it is along with the cation. So what surgeons typically do is they give the patient normal saline and they essentially manage the contraction alkalosis component of the metabolic alkalosis. However, the metabolic alkalosis doesn't return to normal. It will improve somewhat, but it won't go to normal. And the reason is you need to replace the potassium with potassium chloride. And what happens here is when you add potassium chloride to the normal saline, the potassium enters the cell in exchange for hydrogen, and the hydrogen will then get buffered by the excess bicarbonate that is still present in the ECF compartment, converting it into CO2 and water, and the pH and the bicarbonate concentration then returns down to normal. So this is a common problem that we've noticed. Treatment of selective causes of sodium bicarbonate retention. So these are patients with mineralocorticoid excess syndromes or mineralocorticoid-like conditions. It's very simple. If the patient has a high mineralocorticoid disorder, and I'm going to show you a case at the end now, you can either treat with a miloride, or if the patient has primary hyperaldosteronism, to use spironolactone. But by far the most common cause for this is really exogenous steroid use. So, these patients are septic, they get the so-called adrenal doses of steroids. Some of them have acute asthma requiring intubation and are given IV steroids and oral steroids for this reason. And this is a common cause for high mineralocorticoid excess syndromes. And of course, stopping the steroids is what needs to be done. And as I've alluded to previously, patients with chronic lung disease who have CO2 retention may have so-called post-hypercapnic metabolic alkalosis, and this may result in problems with extubation because of hypoventilation, along with the hypokalemia, which causes respiratory muscle weakness. So one needs to treat the hypokalemia. And another option that people have, that some have recommended, is the use of acetazolamide in order to prevent sodium bicarbonate absorption, which is the mechanism for post-hypercapnic alkalosis, preventing the kidney's ability to absorb the sodium bicarbonate, inducing a metabolic acidosis, and then getting the patient extubated. However, when using acetazolamide, there's high delivery of bicarbonate to the cortical collecting duct where potassium is regulated. And as a result, with the high bicarbonate concentrations, potassium will get dragged out of the cell and patients may develop it may worsen the hypokalemia. So you need to watch and replace potassium under this condition. Low GFRs and metabolic alkalosis is a difficult one to treat. If the patient is on dialysis, you simply need to reduce the dialysate bicarbonate ion concentration. However, most of the time, the metabolic alkalosis in patients with a low GFR or renal failure is due to vomiting and the use of a proton pump, omeprazole, will address some component of the metabolic alkalosis. So I just want to end off with a case that I saw recently. In fact, I saw this patient just before COVID hit us. It was a 66-year-old woman known with type 2 diabetes and hypertension and was admitted to the ICU with severe muscle weakness. An examination revealed a blood pressure of 147/72 and hydration was normal and power in all limbs were 3 out of 5. And interestingly, diuretics were discontinued a month before presentation. This was the patient's admission serum and urine electrolytes. So you can see here she had hypernatremia and hypokalemia, and the blood gas down here, a severe metabolic alkalosis with some hypoxemia, likely because of hypoventilation. And when we look at the urine electrolytes, the chloride was high. So what was our interpretation of this? So because the potassium to creatinine ratio was more than 1.5, it was in keeping with renal potassium wasting. So we were concerned of something causing potassium wasting. And the urine chloride was high and her blood pressure was high, and she had a normal ECF compartment. So this makes things like diuretics, vomiting, nasogastric tube suctioning very unlikely. And we need to look at the syndromes of mineralocorticoid excess syndromes or like excess syndromes. So just to remind, so on this algorithm over here, there was no history of vomiting or diuretic use. In fact, the diuretic was specifically stopped 1 month earlier. There was no, there was high urine, the urine wasn't low, the urine chloride was not low, and the patient's effective arterial blood volume was not thought to be low, and the patient did have hypertension, which made us end up in this scenario here, conditions with primary high mineralocorticoid activity. So just to remind you about the physiology behind how aldosterone works. So aldosterone, there we go. It binds to a cytosolic receptor, the aldosterone receptor, which results in the insertion of the epithelial sodium channel or the ENaC channel. And this results in sodium absorption. And because there is a gain of a positive cation inside cells, and because potassium is so abundant inside cells, it is easy for the cells to just excrete the potassium. Now, when patients have hyperaldosteronism, this whole system is augmented, and the ENaC channels, in fact, become more abundant and wider. And as you can imagine, there's more sodium retention causing hypertension and more potassium excretion causing hypokalemia. So our initial thoughts was that this patient must have primary hyperaldosteronism. So we went on to do her renin and aldosterone levels. And as you can see here, this was her actual results. Her aldosterone levels were suppressed as well as her renin levels. So we were now considering a mineralocorticoid like excess syndrome. So just to remind you of the causes of this, cortisol has the ability to bind the aldosterone receptor because it can move intracellularly. However, there's an enzyme in the basolateral membrane of these cells called 11-beta hydroxysteroid dehydrogenase, which actually metabolizes cortisol as it tries to cross this membrane and into an inactive product. So it actually can't stimulate the aldosterone receptor. But as you can imagine, patients with Cushing's syndrome or patients who are given exogenous steroids, this is the mechanism for how it would mimic mineralocorticoid by binding that receptor. Licorice and glyceric acid in particular is an inhibitor of that enzyme, which allows cortisol to enter the cell and stimulate the receptor. And then there's a rare syndrome called AMI, apparent mineralocorticoid excess syndrome, where patients are born with a deficiency of the 11-beta hydroxysteroid dehydrogenase enzyme. They have a deficiency of that enzyme, but that usually presents in childhood. And this patient was already 66 years old. So she was not using steroids. She didn't have clinical features of Cushing's syndrome, and she denied any use of licorice. So the other possibility we were considering is Liddle syndrome, which is a mutation affecting the ENaC channel, which allows the ENaC channel to absorb sodium regardless of whether or not sodium is actually required, resulting in hypertension and hypokalemia. And in fact, she ended up having Liddle syndrome. The patient was commenced on amiloride and the metabolic alkalosis, as well as her blood pressure and potassium, all normalize. So in summary, metabolic alkalosis is the most common acid-base disorder developing in the ICU, and it is most commonly due to a chloride salt deficit. And this is usually due to either diuretics, vomiting, or nasogastric tube drainage. And then the other causes that one needs to look for, where there is actually sodium bicarbonate retention, is due to steroids and post-hypercapnic states in patients with chronic lung disease. The complications of metabolic alkalosis are life-threatening, and this is why it is an important condition to manage, to identify the cause and manage the underlying etiologies. And a systematic approach will reveal most causes of metabolic alkalosis, and in particular, the urine chloride is the first step in the diagnostic process in identifying the etiology. And treatment is really to replace the chloride salt deficit. Thank you.
Dr. Ahmed Twahil has said, I note that urinary sodium is high in dehydration, metabolic alkalosis. I would expect it to be low. Please explain.
Sorry, in patients with dehydration.
The question is, I note that urinary sodium is high in dehydration, metabolic acid alkalosis. I would expect it to be low. Please explain.
Yeah, that's correct, because in dehydration, we expect the tubules to try to reabsorb all the sodium that they can get. Yeah, so what is happening here? Please explain.
So I would really want to know if these patients are using diuretics, or one needs to consider, of course, diuretic-like syndromes, but this would be very unusual. And then the other possibilities are to think of salt wasting syndromes. So, so most likely the patients are either using diuretics, have diuretic-like syndromes, or they have some kind of salt wasting nephropathy.
This is from the slide that you presented in the patient who had contraction metabolic alkalosis. I noticed that the urinary sodium that you put in the table was quite high. So that's why I was asking, how do we get high urinary sodiums in patients who are contracted?
Yeah, so look, it will be difficult in dehydration, they should, or hypovolemia, let me rather use that term. So in hypovolemic patients, you should not be having high urinary sodiums. And I would strongly recommend looking for either a diuretic or salt wasting nephropathy. That's really in other words, it is pathological. It is not a normal response. And if the patient is hypovolemic and is salt wasting, then one needs to go and identify the etiology, of which diuretics are by far the most common.
Thank you.